Hey, how you doing? My name's JJ, I'm a fourth year medical student, and in this video I'm about to share with you what I, clinicians and academics believe are the most important aspects when approaching the AMK, from preparation through to exam technique. So just a few years ago I was in the exact same position as you, starting medical school, and I wish I'd have had one of the students in the older years tell me what I'm about to tell you. So I've met academics and clinicians, I've been through loads of exam questions, and I've covered all of the theory behind the AMK. And what I'm trying to get across is that I've put in the effort so you don't have to. I've aimed to break it down into its most simple, easily digestible chunks for your benefit. Right, now let's find a classroom and get on with it. So there's a number of reasons why you might be watching this video. Maybe you're new to medical school and you've heard about this big scary exam where you've got to sit the same paper as someone that's been studying for 5 years. And understandably, that's a bit scary, especially if you don't even understand what some of the words in the answers mean. Or maybe you've sat the AMK a couple of times, but just haven't got the perfect technique for you yet. Or maybe you're completely happy with the AMK, your results and your technique, but just wanted to see what advice was out there from students, academics and clinicians that have helped put the exams together. So to give you a brief overview of what I'm going to be talking about, first off I'm going to start off with why I've made this video and why I think it's important for you as a medical student to watch it. Secondly, we'll talk a bit about the statistics behind the AMK, and then we'll talk about how to prepare for the AMK, and I've got a myth to dispel there. Then we'll get down to the exam. We'll talk about how to approach the paper as a whole to start off with, and then we'll go right down into it and work on each individual question, how to approach each individual question. And then towards the end, we'll be hearing from an academic and a clinician that both help to put together the exam, as well as a medical student, to hear their top tips for the AMK. And then finally, we'll have Professor Anthony Nichols, an acute medical physician at the RD&E Exeter, to share some of his wisdom in going through some AMK questions for us. So that's what I've got planned. Let's get on with it. Why did I think it was important to talk about AMK technique? Well, from experience at medical school, we've had a lot of education on anatomy, physiology, pharmacology, and the science behind medicine. But little emphasis has been put on exam technique for the AMK. And as I'm sure you'll know, we sit 4 AMKs a year. Each exam has 125 questions in it. So with a quick bit of maths, that's 500 times a year that you can put into practice having good exam technique. And also, people think that doing well on the AMK, you must have to know the right answer every time. But it really isn't about that. It's a lot about working out which answers aren't the right one and narrowing it down and then giving it your best guess from there. And I find when you look at it like that, when you flip at it and look at it, instead of looking for the single right answer, but instead you're looking for 4 answers that aren't right and you're just trying to narrow down, maybe get rid of 2 of them, then that changes the exam and it makes it a lot more fun, a lot more enjoyable. So why video? Why didn't I just do a lecture? Well, hopefully you're reaping the benefits of this now. You can watch it at your time, where you want, and however many times you want. You can recap this once before every AMK or just watch little snippets of it to refresh your memory. But I understand as a medical student how busy we can be, and it's a bit annoying if there's only one opportunity to go to this lecture. So the idea is hopefully that you can be watching this when you want and where you want. Right, so the next topic is the statistics behind the AMK. So if you come and have a look at my screen and then we'll talk through that. Right, okay, let's get into some of the statistics behind the AMK. So there are 125 questions split through 5 blocks, each block containing 25 questions. Each question has 5 answers, of which one of them is the correct answer, and then there's a don't know option as well. You get +1 mark for every correct answer, and minus 0.25 for every incorrect answer. So if you guessed every question completely blind, then you'd get 1 out of every 5 questions right, and this would give you 25 correct answers, and 25 times 1 for the correct answer would give you plus 25 points, and then you'd get 100 incorrect on average. This is So you'd get 100 incorrect, which would be 100 times minus 0.25, which would give you minus 25 points. And that adds up to 0 marks. So on average, if you absolutely blindly guessed every single question, you would end up on 0 marks. So what I'm going to show now is that any improvement on that is going to put you into the plus. So this is what the med school recommend. They recommend answering if you can narrow it down to 3 answers. So let's have a look at that. If you narrow it down to 3 answers, you should get 1 in every 3 questions correct. So this would be roughly 41 questions that you'd get correct. So 41 times plus 1, 41. And that would leave you with 84 questions roughly that you would get incorrect. So 84 times minus 0.25 leaves you at minus 20.25. So add the two together and we come to a nice shiny 20 marks. Hopefully that's shown you that if you can narrow it down to 3, then you're doing really well. You don't need to know the answer in order to do well in the AMK. It's a lot about deducing which ones aren't the right answer. So how should you prepare for the AMK? Well, I'll start off by dispelling that myth that I said I would. So the myth is you can't revise for the AMK. And that's not quite true. What the med schools say is you can't cram for the AMK. And what they mean by that is don't cram for the AMK because it won't help you. And there's 2 reasons for that. One, if you cram, you might get 1 or 2 questions if they come up on the topic that you've worked on. But if you just understand basic concepts and how these systems interlink, then that will come up on a far larger amount of questions, and that is where your knowledge will really build from. And 2, because cramming doesn't work, it doesn't last in your long-term memory. So you'll end up just having to re-cram the same stuff for the next AMK, and then the next one after that. And that leads on to my next point. So if you learn something and you truly understand it by making associations, that's how it sticks in your long-term memory. And now you're probably thinking, how do I learn a topic so that I truly understand it? So in order to answer that, let's have a look at this diagram to help me explain it. So we've got a rough overview of Parkinson's disease here. So we've got the anatomy and physiology, so that's what happens normally in a healthy person. Then you've got the pathophysiology, what's gone wrong in someone that's got Parkinson's. And then finally there's the treatment and the complications. If you're in first year, maybe second year, you might not have come across Parkinson's disease yet and might not have covered it in depth. So if you then go in and try and learn the treatment and complications, then it's not going to make much sense to you. You're going to be learning about something that you don't understand the basics of yet. So if you don't know the pathophysiology, what's gone wrong, how are you supposed to know what to treat it with? And if you don't know what's right normally, how are you supposed to understand what's gone wrong? So in Parkinson's, it's characterized by the accumulation of proteins into Lewy bodies in the neurons. And also there's insufficient formation and activity of dopamine in certain parts of the midbrain called the substantia nigra. But if you don't know what the substantia nigra are, then you won't understand what goes wrong with them. And then even further on than that, you won't understand why do we use L-DOPA as the treatment? Why do they have this complication of trouble swallowing or a quiet voice? Whereas if you understand the basics, all of that will make sense. And then instead of just trying to remember a fact, which is what they are effectively, remembering that L-DOPA is the treatment for Parkinson's, it's a fact unless you understand the basics. But if you understand the basics, then it just makes sense that if you're deficient in dopamine, then you can give a dopamine agonist. So if when learning for the AMK you look up the treatment and complications of all these complex disorders that you don't understand yet, it will not stick in your long-term memory. So what I'm trying to say is focus on what you understand already. Focus on anatomy and physiology, get a good base, and then from that learn the pathophysiology, what goes wrong, and learn what goes wrong in common conditions, because then you get a solid basis, you get a solid foundation, and you can grow from there. and then in the later years you can start delving into more niche topics. But I really think this will help you long term, because if you're learning about these type of topics that you understand, then you won't need to have to relearn them again as if you would if you were just learning topics out of the blue. You would just simply need a quick recap on them, and then you're good to go again. So now, how do you do that? How do you revise for the AMK? Well, focus on your curriculum. Focus on the anatomy and physiology in PBL, in LSRC. Get a good strong base of anatomy and physiology before you start moving on to pathophysiology. Or look up pathophysiology associated with the anatomy and physiology that you've just covered. If you learn them together, then those connections will stay with you, and that is what memory is, just making connections. So focus on the anatomy and physiology in PBL and LSRC, and you'll develop from there. And another thing to do whilst preparing for the AMK is get a study buddy. And this is for the AMK and for any learning you do, especially in the early years. This is really useful. The learning you do is so much more effective and enjoyable when you do it in pairs. For example, with the AMK, you can go through questions together. You can talk through each other's thought processes about how you might approach one question differently to someone else, or they might have picked out a point that they thought was really important that instantly told them the diagnosis. All of this requires active learning, so you remember it more easily, and it's far more enjoyable for you. So you won't find working as much of a stress, and you'll be able to work more. Right, now let's talk about exam technique and how to approach the paper as a whole. Now, before we go any of this, there isn't strictly one best way to tackle this type of exam, and if you ask 5 students how they approach it, you'll probably get 5 different answers. So I'm going to provide you with 2 options, one that the medical school advises and one that seems to be used by a lot of medical students. They're both similar and they both have their own advantages and disadvantages. So it's all about just finding out which technique is going to work for you and then implementing that. So first up is the technique that the medical school advise. And they say to skim steadily through each section, spending no more than 30 seconds with each question. And then each question will fall in one of 3 categories. Either you'll definitely know the answer. For example, how many sides does a square have? 1, 2, 3, 4, 0. There's no problem there, 1 point in the bag. Easy. And you hardly had to think about that. There'll be a few of these questions, probably no more than 4 or 5 to begin with. Mark the answer paper straight away and move on. With that one, make sure that you've read the question carefully. There have been some questions that have popped up in the past that people think are too easy and they've just marked it straight away when they've missed a key word in the question. But this follows with all of them. Read the question carefully. The next category is where you definitely don't know the answer. And often it's because you don't even understand the words in the answers. And I definitely felt that a lot as a first year. And don't get scared by that. There will be a lot of these type of questions initially where you don't understand any of the answers or you just have no idea. But as you progress through the medical school, the number will go down. But do remember that even an experienced clinician will have questions that fall into this category where they just don't know the answer. And then finally, there are the questions where you think you know the answer, but aren't quite sure. Now these are the questions where you can raise your score, so they are the ones to spend your time on. So now you've had a quick skim through the paper, you've sorted out into 3 categories. The ones you definitely know and you've already marked, the ones you definitely don't know, where you probably won't spend time on unless you've got time left over at the end. And then there's the most important category, the ones where you think you could work out the answer. The reasoning behind leaving the questions that you're unsure about is that it activates your subconscious recall mechanisms. So an everyday example of this is when you walk down the road and meet someone whose name completely escapes you, only to have it come back as soon as you walk away. Well, this is the same thing. You've activated your subconscious by the first read through, and then you're more likely to be able to bring it to mind the right answer when you come to look at it a second time. And then another thing, and this happens surprisingly a lot, there may be questions at the end of a paper or at the end of a block that will help you answer questions at the beginning. So an example I remember from a paper I sat just last year was one of the questions asked, what was the biomarker for ovarian cancer? And then in a later question in the vignette, talking about a lady with ovarian cancer, it said that the cancer was confirmed by the biomarker CA125. So by reading ahead, I was able to look back and then answer that question. And then the second approach is the common approach that most med students that I've spoke to take. And that's just to go through each section in one go and don't look back. And so the similarity is that you mark the no-goes, the ones that you just don't know, because there's no need of wasting time on them trying to guess them, and just do the block in one go, be confident and move on. And there's pros and cons to each of this. So the medical school style has the pros of that it lets your subconscious do that work that we spoke about. And it means you don't miss the easy marks. As we spoke about, you go through the whole paper and you answer the ones that are the easiest to get. So the common approach has some pros, is that there's less time spent reading. You don't have to read the questions twice as much. You just focus on it once and move on. And a lot of the students that I've spoke to choose this because they found that they never changed their mind anyway when they went back to a question. If they had an answer in mind, then they always stuck with that. So they worked out that it didn't help them going back. So it works for some people, doesn't work for others. So it's really about just picking what technique is going to work for you and just getting familiar with it. So now we've spoke about how to approach the paper as a whole, let's get down to each individual question. So there's two main ways of approaching a question, and really that depends on how much you know. If you're in first year, you might want to just glance at the answers first, because if there aren't any answers that you know, then you're not going to be able to answer this question. So for that reason, you could move on. But it would be good to get into the habit of getting used to this next technique, which is what the med school recommend, and most of the students that I've spoke to choose this technique. So for almost everyone, the best way is to cover the answers first. Then once you've covered the answers, read the question. First of all, it tells you if you even need to read the vignette, because some questions will ask, what is the mechanism of X drug? And if they ask you that, then you know you don't need to read the vignette. You will just waste time reading about the vignette, because all that question is asking is what is the mechanism of that drug. Secondly, it gives you the context in which to read the question. So if the question's asking what's the management of this condition, then you don't need to worry so much trying to pick up the signs and symptoms, because it's going to tell you the diagnosis. Then all you need to do is focus on the management of that condition. Once you've got a question in mind, then move on to the vignette. And every detail is in there for a reason, to either push you towards or away from a diagnosis. So mentally highlight all the important details. As a way of doing this, some students find it really useful to try and imagine the patient. And this might be hard at first, but the more you do it, the better and the faster you'll get at it. For example, age is a critical factor in the early years, and the med school want to test, are you taking into account the patient's age? So if the patient's above 50, then the diagnosis of some form of cancer is far more likely. And that's just the type of thinking that the school want to check that you are building up as you go through the medical school. Then, once you've read the vignette, go on and read the question once more to remind yourself of the exact wording of the question. And you've got to be really careful with this on AMKs, because there are quite a few different styles of question, and what is the next step in management is different to what is the most important step in management. So that's just another little tip, is just read the question really carefully and make sure you understand the wording of what each question means. Now, with the answers still covered up, try and think about what your answer would be. You don't have to have an exact answer, but as long as you have a rough idea of what you're thinking the answer might be. Then uncover the answers and see which one fits closest to your answer. If there's a match, then mark it and move on. But it's important to note at this point, even when you're in the later years, the vast majority of questions you won't absolutely know the answer. And this is exactly why technique is crucial if you want to do well. And then if there isn't a match, this is where you can use the opposite approach. Instead of trying to work out which answer is the correct answer, you can work out which answers aren't the correct answer. So instead of looking for the one answer that is correct, you're now looking for 4 answers that aren't correct. And even if you only get 2 of the 4, then you've narrowed it down to 3. And as we spoke about earlier, if you narrow it down to 3, you really should go for it. But again, a reminder that you need to be aware that if you are going to take an educated guess like that, then you need to be certain that the answers that you're ruling out are definitely not the correct answer. So now hopefully you'll have narrowed most questions down to a few. You've then got to work out, how do you choose which answer is the right answer? Do you go with your gut instinct, or do you try and really work it out, basing it on what you can think of, your medical knowledge at that time? Because there is evidence that shows that if you answer with your gut instinct and then later come back and change that answer, then you'll be changing from a correct answer to an incorrect answer. So it's really about just finding about what works for you, but really trust your gut instinct, because oftentimes that will have come from your long-term memory, and there will be some basis for that reasoning. So as I said, that's it from me now. I'm going to hand over to Professor Nichols and Dr. Kevin Brandham, who've both helped put together the AMK. So they're really good people to hear their top tips from. So here we go, Professor Nichols.
Hi, I'm Anthony Nichols. I'm a physician, consultant in acute medicine in Exeter, and for many years I used to be involved with setting the AMK papers, but I don't any longer do that. What I do know is that when you, in the early years, see the papers, you'll be frightened. So the message is, don't panic. There will be stuff in there that you know a little bit about. Focus on those. Ignore those questions you don't know anything about. You'll learn about those in the later years, but there will be questions which are picked out that are covering some of the topics you've dealt with in your early curriculum. So the message is, focus on what you know, don't panic on what you don't know.
Hi, I'm Kevin Brandham. I'm the Deputy Director of Assessments at UEMS. And what's my top tip for the AMK? Well, it's really simple. It's focus on the curriculum that you've experienced to date. The biggest mistake a number of students make is to try and cram extra little facts that they think might come up on the exam that they've not covered yet in the curriculum. And this really just defeats the whole principle of what we're trying to achieve. If you concentrate on the curriculum you've experienced to date, understanding that to the best of your ability, you'll get a score that reflects truly where you exist in the curriculum, and we'll be able to track that over time. You will improve as you go through and gain more knowledge, and we'll see that improvement over the year and then the subsequent years of the curriculum.
Hi there, my name is Salil and I'm a 4th year medical student. My top tip for the AMK is if you can narrow each answer down to 3 options, I'd definitely recommend answering it. Also, I'd recommend after each exam maybe jotting down a few topics that tend to come up, because the same topics reoccur and it's nice to have a list after a few years.
Okay, great. So now we've had some top tips. It's time to put into action what we've been talking about and go through some past questions. So we've got Professor Nichols here again to go through some questions with us, and these are exact questions that have been taken from AMKs in the past. So the idea here is to concentrate on and practice what we've spoken about today. So even if you come up to a question and you feel that you don't know the answer, just see if you can work out, using common sense or the medical knowledge that you already have, see if you can work out a few of the wrong answers to start ruling them out. And then have a listen to Professor Nichols and see the types of thought processes he uses to answer these questions. Right, let's get on with that.
So now let's have a look at some real questions here. How do we approach these questions? We've got a little vignette in a fairly standard format which tells you the setting, history, an examination, and then there's a question which is in bold, and there's a list of options. What you need to do is to start by reading the question. It says here, what's the most likely diagnosis? So you've got to get in your brain. You're after a diagnosis. Glance at the options. Don't read them in detail, but there's a series of diagnoses here that you've probably heard of some of these. So let's go back and see what the problem is here. The man says he's got burning numbness in his feet, a weakness in his legs, and there's an examination which shows he's lost his ankle reflexes. They would tell you if he'd lost his knee reflexes, so those are present. And it tells you there's impairment of light touch and pinprick from the knees down bilaterally, which is a distal sensory loss. Now, when you have sensory loss, one of the things you need to realise is there's only certain patterns of sensory loss. The sensory fibres travel together to the spinal cord, and then they divide into light touch and proprioception travelling in the posterior columns, and pain travelling in the spinothalamic tracts. So it's unlikely there's going to be a problem in the spinal cord here. So if you look here, multiple sclerosis is a central nervous system disease which can involve the sensory pathways in the spinal cord, but it's unlikely to cause this very distal pattern of sensory loss. So let's look at some of the other options. Option E there, polymyositis. What does that mean? Well, itis is an inflammation, myo, that's muscles, and poly, inflammation. So inflammation of lots of muscles. But we're dealing with here with sensation, whereas muscles are purely involved with strength. So we can rule that out. Disease of muscles won't cause sensory loss. Again, let's look at option B, motor neuron disease. It's a condition that's well publicised in the lay press because of its ability to paralyse people, often at a young age. But it tells you it's motor neuron disease. The clue is in the word. It doesn't involve sensation. How about lumbar disc prolapse? Well, lumbar disc prolapse is common, and when you have a lateral disc prolapse, it catches the nerve roots as they emerge, typically at L5 or S1, and if that was the case, you would have a dermatomal sensory loss in the distribution of that unilaterally, whereas this man has got bilateral disease in a stocking pattern rather than a dermatomal loss of a nerve root. There's a clue here, of course, in option D, which says the word peripheral, because they're telling you that something is peripheral. And one of the features of peripheral neuropathy is the sensory loss is described as being glove and stocking in pattern. And of course, our stockings might go up to our knees. So it sounds like this man has got a stocking loss. So let's recap in this question. This man has got numbness and loss of pinprick, weakness and loss of reflexes. So there is involvement here of the motor system and the sensory system. Motor neuron disease you can therefore rule out as it doesn't involve the sensory system. Polymyositis you can rule out because the muscles don't involve sensation. So even if you know nothing else, you might narrow it down to lumbar disc multiple sclerosis and peripheral neuropathy. So 1 from 3 is better than 1 from 5, so give it a go. If you pick up the word peripheral and go with that clue, you'll be even better. This question looks very clinical, looks pretty much beyond what we want year 1 and 2 to know about, because it's a diagnosis question based on an ECG. Let's take it apart here. We've got a man who's got retrosternal chest pain, which is made worse by inspiration and relieved by sitting forward, and there's an abnormality on the ECG. Option A, what's all that about? Costochondritis. Costo, rib, chondro, cartilage, itis, inflammation. So an inflammation of something to do with the cartilage of the ribs. Doesn't sound plausible that would affect the ECG. So it doesn't sound very likely. Myocardial infarction, abnormality of the ECG. You might put it on hold, let's think about it, but this man has got a 2-week history of a flu-like illness. Now, myocardial infarction is very common, and we all know that myocardial infarction is pretty sudden. People develop their symptoms over a matter of minutes or hours, not 2 weeks. So myocardial infarction sounds implausible here. Pericarditis. That's normally a viral infection. Oh, flu-like. Viral infection. Pericarditis, inflammation of the heart. Pain? Hurts when you breathe? Well, your pericardium moves when you breathe. The fact of the matter is that ST segment elevation in all the leads is classical of pericarditis, which is why it's the right answer. Pneumonia. Yes, you get pain when you breathe in pneumonia, but you're not going to be likely to diagnose pneumonia on an ECG. You wouldn't be surprised even in year 1 at medical school, or even as a lay person in the street, to know that we diagnose pneumonia on a chest x-ray. So basically you have to be real and simple on this. No one's going to diagnose pneumonia on the basis of an ECG. Pulmonary embolism. What does that mean? Well, embolism means the movement of something through blood vessels, in this case a blood clot, to somewhere else in the body. Pulmonary embolism is sometimes called economy class syndrome. You get a deep venous thrombosis, the clot moves to the lungs, goes through the heart, goes into the pulmonary arteries, and can be fatal, but in a subfatal condition it can cause pain, breathlessness, an abnormal ECG. But it's a sudden condition, not a 2-week history. So we don't like that one. So let's go back to basics again on this one. We've got a series of conditions here where we'd expect you to know that pulmonary embolism and myocardial infarction are sudden conditions. We've got a condition you may not have heard of called costochondritis, but from unpicking the words, you can work out it's an inflammation of the cartilage of the ribs. Not likely you get an ECG abnormality on that. The 2 other questions we have here, pericarditis and pneumonia. Both of them might be plausible on this story, but the ECG is classical of pericarditis and the history is typical of the age and the sex and all the features. So at least you can narrow it down to a few from what seems like an impossible number. This question here is about a young woman who has a range of symptoms involving a goiter, exophthalmos, lid lag, tremor, tachycardia, and it tells you prescribe propranolol. It's a 2-step question in some ways, where you've got to make a diagnosis, and then you've got the rather difficult question saying you give propranolol and what would persist despite this therapy. Now, because there's a goiter present, we would expect you to know that goiter is a disease of the thyroid. And apart from cancer, which is rare, a thyroid gland is either overactive or underactive. And I guess it's not too tricky to work out that if your heart rate is fast and you're sweaty and losing weight, you've got an overactive thyroid. So I think we would expect most people to work out this is an overactive thyroid. The tricky thing here is then you're giving propranolol, which is a beta blocker, and it will block those sympathetic overactivity features, but the ones that are not due to sympathetic overactivity would persist. Well, sweating, tachycardia, tremor all sound like sympathetic overactivity, and they get better with giving a beta blocker. What about the eye signs here? Lid lag. Lid lag is due to sympathetic overactivity keeping the eyes staring and wide, and that will go away with propranolol. But finally, exophthalmos, the tricky one here, this is due to the fact that the woman has an autoimmune disease, Graves' disease, where there is inflammation of the retroorbital tissues which push the eye forward. A bit more tricky, but at least you can knock out C, D, and E as classical sympathetic overactivity features. How about this question? I'm not a paediatrician. I'd never see a 14-year-old child. I'm not a GP. I'm not a paediatrician. But let's have a look and see the story here. You're in general practice and you have a 14-year-old girl who's got a completely non-specific history, headache and tiredness? Who hasn't occasionally had a headache? Who hasn't occasionally felt tiredness? Use your lay knowledge here. It's unlikely you can make an exact diagnosis. It then tells you that 6 months earlier she had similar symptoms when she had infectious mononucleosis. Infectious mononucleosis is the fancy term for glandular fever due to EB virus infection, and it tells you she got well after this but had similar symptoms. They then ask you what's the most important next step in management. Well, the clue is in the fact that we've got too little information. We have completely non-specific histories of headache and tiredness. So before you start referring to a paediatrician, arranging a CT scan of the head, doing blood tests, or getting in touch with a teacher at school, you need to get some more history. It isn't enough there. We've deliberately done it this way because patients sometimes push you to make a diagnosis when you just don't have enough information. Maybe this question is too simple, but sometimes people jump to conclusions without getting more information.
So if you're watching this as part of my DAT, then first of all, thank you very much for watching it. Secondly, if you could fill in some feedback, that would be great. There should be some feedback attached. It would just be really quick, what you thought went well, what you thought I could improve on, and hopefully, has it reduced the anxiety for you around the AMK? Because we know it's a big, scary exam. Has it helped you to just give you a bit of relief knowing that you've got a technique to stand by? Yeah, so let me know your thoughts, but thank you very much for watching it and best of luck in the AMK.